So we have Dr. Aimee. She's an IVF and fertility doctor, and she's going to talk about physician hesitancy around polygenic screening.
Well, thank you so much. You guys are all very sweet. I was super excited to be invited here. I thought there was a mistake. I saw all the smart people and I was like, did you guys mean to invite me? But I'm just so glad to be here because helping people have healthy babies is really near and dear to my heart. I see about 30 patients a day, 7 days a week. I probably have over 9,000 patient contacts a year. I do over 700 IVF cases per year. That's a lot of families that I'm trying to help. And the one thing that they all want is a healthy baby. The fear that most people have coming into IVF is somehow IVF is going to cause them to have a baby with autism. And so that's the one thing that they all are scared about, that somehow they're going to go through this treatment and they're going to have an autistic baby. So for me, having a technology that potentially could minimize that risk is pretty exciting for me. So that's one of the reasons why I offer patients polygenic testing in my practice. So I'm kind of rare. I'm a little bit out there. So I'm one of the first adopters of a technology if I think that it can help my patients, but not all doctors are like that. And so I know the attitudes and the opinions of a lot of the doctors because we talk and I hear them, and we're in Facebook groups and we kind of chat about different things as headlines hit the news. And so I know that I'm not the norm, but I know that I've always been not the norm since birth. And along those lines, I know that things take time for doctors to change their attitudes and practice, a lot of time. So I'm just going to talk a little bit about polygenic testing. You guys have heard a lot about that. Barriers to adoption, why patients leap before physicians, why it's so controversial, and a way forward. So the promise of polygenic testing for me, like I said, is that what patients are most afraid of. And they come in saying, if I do genetic screening of an embryo, does that mean I'm not going to have a baby with a birth defect or autism? And unfortunately, we can't offer them any types of reassurances like that. I also have patients who, let's say, have a family member with schizophrenia, and now I can offer them something to minimize that risk. Patients come in with a history of type 1 and also type 2 diabetes, or a strong family history of coronary artery disease or Alzheimer's and other neuropsychiatric disorders. And so this testing is very helpful for them. But not all patients know about it, and that has to do with the fact that doctors aren't talking to their patients about it. So if there's a technology like this, why isn't every IVF clinic doing it? Why are doctors so hesitant? And so, we rely on these governing bodies, so ASRM and ESHRE, so American Society of Reproductive Medicine, and then the European counterpart. They have made no formal recommendations when it comes to supporting polygenic testing, and IVF doctors tend to be more conservative, and we rely on them to tell us, it's okay to do this. Let's take some examples that you guys probably already know about. So for example, egg freezing. Egg freezing was considered experimental until not that long ago. So doctors actually tell women egg freezing is experimental. I mean, I've been freezing eggs since my training in 2005. It took almost 10 years for that experimental ban or that label to be lifted. Look at carrier screening. So I was on, this is Diane Sawyer, World News Tonight. I was interviewed about carrier screening. I was one of the first doctors in this country to offer something that now is so basic and commonplace, but it took almost 15 years for other doctors to start offering it to their patients. But I knew right away that this was going to help people have healthy babies. The next example would be NIPT testing, so non-invasive prenatal diagnostic testing. Most of you probably know what this is, but this is a blood test that can be done at 9 weeks of pregnancy. And it looks at 6 of the most common chromosomal abnormalities. It can also tell you the sex of the embryo too. I was one of the early adopters. My clinic was actually a clinical trial site for Natera when this test first became available. And my how old is he now? Don't ask, I have 4 kids, I never remember how old they are. 13, and so he was one of the first babies to ever have the NIPT test. And when that test first was available, doctors were, freaking out. They were saying things like, people are going to start having abortions because they're going to find out that their baby's a boy too early in pregnancy. And there was a lot of fear mongering, but now here we are in 2025, it is the standard of care. So that kind of pattern is very common amongst fertility doctors, OBGYNs. I tell companies that it'll take years for this to be something that can be introduced in the clinic. You know, you'll have the early adopters like me, and then as long as you have some famous people doing it and talking about it, then other patients will do it, and then it'll be more consumer direct, and more patients will be asking for it, and then doctors will know that they have to offer it. Fertility doctors were the first ones to get blamed for things, and that with that comes some, I don't know that there's that much liability, but we tend to practice more defensively. So I'm frontline. You know, when I offer a patient a test and they get pregnant and have a baby, and what I'm talking about is IVF with PGT for aneuploidy, which I call PGT ambiguous. When a patient has a problem with their baby, I'm the first one they call. And I'll just kind of share some of the stories that, you know, I've experienced in my career. So I had a patient who had a baby and then a child. She was like 5, and her baby had very thin hair. Like, you wouldn't think that somehow I would be blamed for that, but she was like, my baby has thin hair. Did IVF cause this? I had a couple, they had a child at their 6-week postpartum check. The doctor said that the baby was going to be shorter than she expected. So she calls me and she says, my baby's going to be short. And I was like, it's a baby, and why am I to blame for this? And I've had other more serious things where a child's diagnosed. I've had about 2 or 3, again, last 18 years. So we're talking about a very small percentage of children who have been diagnosed with cancer at an early age. I get the call. I'm the first one they think of because they want someone to blame. So did IVF cause my cancer? So you can imagine with a technology like this, if we're wrong, if, let's say, we are promising something that we can't deliver, I'm going to be getting the call. I'm going to be blamed. And so there's this fear that we're offering something to patients that we can't deliver on its promise. So it kind of feels like this slippery slope also toward eugenics. There's a lot of talk about, you know, I'm already hated. So you can actually find this article. It's in a Catholic magazine, and they actually, and I'm very proud of it, if you can't tell, where they call me the devil. And I'm like, yes, I've made it. But I've been the devil, you know, for a long time, as it relates to like offering egg freezing and IVF. But this is, you know, part of that prejudice that people have against IVF doctors and what we do, because they think that we're doing something that I don't think we are, and that is creating designer babies, where we're very simply put, for me, is I'm trying to have people have healthy families. That's the goal. That's the reason why I do what I do. That's the reason why I explore different options when it comes to genetic screening, so that I can have healthy babies. And I don't get those calls about being blamed for things that are not my fault. So the skepticism is around whether this will actually really change outcomes. And if not, are we adding complexity and cost to an already expensive process? So I think cost is one of the biggest barriers when it comes to doctors offering this test, because it's not a test that we can offer to everybody. It is not accessible to everyone. Not everyone can afford it. They're already doing something very expensive. So I think that has a lot to do with it. We also have had experiences with technologies that we might have adopted or thought would be like amazing, and it turned out that it wasn't that case. I'm not sure if anyone in this room has heard of a company called Ova Science. They were, yes, I actually sent many patients to Canada, many, and you know, they had this, they claimed that they had identified the stem cell in the cortex of the ovary that could rejuvenate eggs, and if they inject it into eggs, then, you know, this could improve outcomes in IVF. So, you know, I was, again, you know, when someone has, you know, you feel like it's between their own eggs and donor eggs, I actually sent patients there, and, you know, I don't think any of the owners of the companies are in the US anymore. So we want to review the positive long-term outcome data before changing what is known to work. But what is known to work actually, frankly, sucks. So it's terrible. I mean, patients are told that we can genetically screen their embryos. And if you ask a patient what that means, they think that that means their baby won't have autism, their baby won't have a birth defect, and everything is normal. But that's not the reality, because the technology that we have is not as good as it really should be for where we are here in 2025. The other thing is that, you know, if someone is going through IVF and there's the possibility that they could get more data, I feel it's unethical not to offer them what is available to them. So I, unlike other clinics, I present them the different options, and then they can choose for themselves what is right. They can do genetic counseling with the different companies, and then they can decide if they want to move forward with whole genome sequencing or not. So patients make the leap a lot of times before physicians for a lot of these kinds of tests. And so that kind of is what drives physicians to then adopt these tests, because patients are asking for them. You know, patients are reading about it on Substack, Twitter, and Reddit, and then they're saying, well, why wouldn't I do something like this? If I'm already, for example, going through IVF, why wouldn't I also, you know, prioritize embryos based on polygenic scores? And the consumerization of IVF is driving interest faster. So a lot of people realize that, like egg freezing, embryo freezing is another way to preserve fertility. And fertility medicine is now a part of preventive medicine, which I think is very exciting for me, because I think it always should be. It should be a conversation we have with every woman before the age of 25 and man, and talk about, you know, what are you thinking as far as your future family? And, you know, do you want to preserve your fertility, do egg freezing, and make embryos depending on your situation? So this is controversial for a number of reasons, because we're talking about genomics, ethics, economics, and emotion. And we're no longer just treating infertility. We're also being asked to optimize future life outcomes. And that's a huge responsibility, especially if we don't get it right. And then the disparity part is the hard part for me, because I want everyone to have access to everything. And the reality is the accessibility just isn't there quite yet. But I think over time that will not be as much of an issue. And the other concern is for trait-based discrimination. So I can't create something that a patient doesn't already bring to me. So I can't have someone who's coming to me with black hair, brown eyes, and give them the blonde baby that they want. As an example, of course, you can't do that. But those are some of the things, trait-based discrimination, that people are concerned about. And then the other thing about what else fuels the controversy is just language and how we explain tests to patients. You know, patients don't know what PGTA is. They don't know what chromosomes are. They don't know what carrier screening is. So as part of my fertility checklist in every single patient, I offer patients chromosome analysis and carrier screening. A lot of them already come to me with carrier screening, and then I say, I'd like to do a chromosome analysis on you. And they say, well, I already did that. I already did that with Horizon, the Horizon test. I already had my chromosomes checked. I'm like, no, you didn't. I said, you only did carrier screening. You didn't do chromosome testing. They'll have a strong family history of cancer, and I'll say, like, I want to do your inherited cancer gene test. And they'll be like, well, I already did that. I did carrier screening. I'm like, no. Carrier screening only looks at autosomal recessive genes to see if you're going to pass on a disease to your offspring that's lethal, and it really isn't that helpful when it comes to what I'm talking about, which is cancer gene testing. So people just lack this basic understanding of actually what's being tested for, and I think that we just need to do better explaining to them what we're testing for, so they don't make these false assumptions about what's happening. And what they're seeing in the headlines is a lot about designer babies, and what we have to do is talk to them more about having healthier babies and healthy families. And that's what this is about. This isn't about genetically engineering the child that you want based on your desires. It's about giving you a choice that's more than just looking at chromosomes to help you have a healthy family. So in order for us to accomplish that, What we need are clinics, which is just not there yet, the IVF labs, it's not there yet, ethicists, we're far from there in terms of ethicists being on board. We're getting closer, but we still have a lot of work to do. Polygenic testing companies, everyone together needs to align on responsible frameworks for offering these tests. And this involves consent, counseling, and education. When it comes to this kind of stuff, oftentimes it takes someone very, very famous to have a story and put it out there and talk about it. Then all of a sudden people understand what we're talking about and why it's so important. And I don't think we just have that yet. And I know that sounds silly, like no one cares about my patient telling her story about her IVF cycle on a YouTube channel. But all of a sudden, if my famous patient had a baby with a mosaic embryo, then all of a sudden all my patients are like, oh, mosaic embryos are just as good as euploid embryos, and I should give them a chance. And I'm like, well, I've been saying this for 10 years. This isn't new, but if someone more prominent shares their story about how technology helps them, then for some reason in our society, it makes it more understandable, more relatable, and something that they're more open to doing. In order for doctors to do anything, and to have, let's say, other clinics approach things like I do, as far as offering patients a test, and then the patient can choose what they want to do, doctors really need to see prospective longitudinal studies of children from polygenic screened embryos over time. Without that, it's going to be really hard for clinics to 100% adopt across the board this technology. But there are things out there that that if you were to look at other examples, like embryo freezing, PGTA testing, or ICSI, we adopted these things without those kinds of studies. And now they're integrated 100% into our practice. So doctors and patients just need more information about them so that they can make decisions as far as whether they're going to use them for their treatment or not. So we really need to be honest with patients. And I think honesty just has not just to do with what's offered, but honesty with PGTP, but honesty especially with the technology that they're using right now, which is PGTA, which just isn't there. But I feel like for me, the data is still early, but promising, and patients shouldn't be sold something. They should choose to opt in and understand what the limitations are. Like, we can't promise them anything. We can't guarantee them anything at all. So IVF doctors are much like me. Like, we're happy, we're kind. We really want to see patients. Like, we go into this field because we're talking about like building love and creating more love in this world. And I think that we tend to be innovators by nature. We go into this because we like learning about new technologies, and our field is constantly changing. But most of us are very cautious because we know how high the stakes are. Because again, like I shared in the beginning, when someone has a baby with an abnormality or a birth defect, the first person they call and they blame is us. And so that's a lot of responsibility for us. So, I take that responsibility very, very seriously. But polygenic testing may not be standard yet. I do think that in the next 5 years, it will be. I feel like most clinics will be offering it to their patients just like I do. And they will be driven to offer it because so many of the neighboring clinics will start doing it, and they'll have no choice in order to retain the patients that they will have to offer it in their practice, whether they like it or not. And that's something that I think we'll see happening more and more of. So that's basically my thoughts on physician hesitancy and why most clinics aren't doing it, and what we can do better as a group to improve that. Oh yeah, absolutely.
Yeah, let's do it.
Yes.
Yeah, I like the point about transparency. I think that's especially important for complex technologies that most people simply don't understand. So to try to explain as clearly as possible the limitations. But I wanted to ask about probabilities. I've heard a lot of people say the following: doctors don't like to explain probabilistic diseases to patients, but I find that puzzling because everything is probabilistic, literally everything, but all of medicine is probabilistic. Chemotherapy is too. So why? I mean, even with monogenic conditions, the BRCA genes, imperfect penetrance. So what is this point about probability?
I don't know. I mean, we can take another example, and that is implantation potential for embryos.
Mm-hmm.
That's all probability,
Right.
and it has everything to do with the score that the embryo gets and the quality of the embryo. But doctors say things like, oh, quality doesn't matter. It's all 65% no matter what you get. And I think it just has to do, not with laziness, but just like people don't want to take the time to talk to people anymore. You can take your scores, put it in ChatGPT and say, explain my embryo quality to me and tell me what the probability is for each embryo. What's the probability that I'll have 2 kids from this batch of embryos, 3 kids, but people just don't have those conversations. And I think a lot of it just has to do with time in the office and bandwidth, and people are just burned out and they just don't like talking to people anymore. So if we created a great AI model, which I'm sure you're already thinking of, I think that could solve the problem where patients can have those questions answered without even talking to their physician. You have to pick for me. This is too hard.
I'm very glad you mentioned oversize because I think that's a perfect example of what we should not do as this field. What sort of evaluations do you think would be most convincing for gaining trust of IVF clinicians in terms of like sibling cohort validation or like other benchmarks? What do you think would be the most convincing?
I mean, I think long-term data is going to be the most convincing, and that's really hard because long-term data takes years. So, right? I mean, that I think is going to be the most important, but that's not the best way to grow a company and to get doctors to be convinced quickly.
Yeah, just like as a follow-up, so yeah, long-term data is probably the most convincing thing, but has there been anything in like your discussions with other doctors where you've sort of like made the case for this test that other doctors have found convincing from you, or is it sort of more just like collectively you find it convincing?
Well, I'll just speak very frankly and honestly, they're disgusted with me.
Do you think there is anything that might work?
I don't know. I mean, like, yeah, I mean, if you look in the Bay Area, there are very few of us that offer whole genome sequencing. And so it's slowly changing, but these big network clinics are not doing it. And I think a lot of it has to do with like the time the clinic has to spend with each patient. These kinds of conversations take time, and there isn't a system in place for that. So, you know, because I'm in these Facebook fertility groups where we talk about things, and it's like they all have this one opinion about whole genome sequencing, and it's far different than mine. And they think that doctors who offer it are creating designer babies, which is really strange to me because we're all in the same field, and it isn't about that. They don't want patients just to come to them who don't need fertility treatment and are doing this to prevent future disease. And I cannot relate to that, and I can't get someone. I was talking to a doctor at a very nearby university, and she, like, I mean, we were having a very pleasant conversation about something, and like, I brought up whole genome sequencing, and she was not for it, to put it mildly, and was, you know, so it's like, I don't know how to change their hearts and minds, and I think the only way to is to have patient stories and showing how much it's impacted them in a positive way. Yeah.
Actually, if you wouldn't mind, can I ask a follow-up on that? So it's maybe a strange question, but so you said discussed.
Yeah.
Is that right? Can you say like another couple sentences about that?
Yeah, I mean, they feel like somehow, let me just see how I can explain that feeling. It's like I'm just doing something that no one approves of. And I think it's not necessary. Yeah, I mean, it's not, I mean, I'm used to that. I'm okay with that. I just feel like a lot of it has to do with that statement of, you know, taking care of people, thinking of fertility medicine as preventive medicine. And I encourage people, so I have all these golden rules, and one of my golden rules is if you're 32 years old, partnered or desiring to have a baby on your own, consider doing IVF to preserve your fertility. I mean, we talk about egg freezing all the time. So, and if you're going to be doing genetic screening, why not also learn about all the things that you can learn about when biopsying your embryos? So there's this feeling that is an overuse of resources, and their labs are already quite limited in terms of what they can do and the manpower there. So I think a lot of it has to do with that sentiment. Yeah. So that one.
So going back to like the 70s and 80s when IVF was brand new and like all the ethicists were, mad about it, were there any lessons learned that we can apply to today? Or was the thing that happened back then is just doctors just started doing it and the bioethicists, they complained a lot, but ultimately they just couldn't stop it?
Yeah, I mean, it's the same thing with egg freezing. So egg freezing, similar thing more recently is like, oh, egg freezing we're forcing women to stay in the workplace longer. And, the reality is women are egg freezing because of most of them are doing it because they don't have a partner. That's the reality. That's what the sociologists are seeing, and that's what I see as well. So, so I feel like, it's that same thing. Is like we're doing it, the ethicists are upset about it, and eventually, it's going to be part of our IVF offerings in the near future for everybody. Yeah, Divya?
I was wondering, the responses you gave of the other physicians around polygenic scores, or just offering that as a test. I'm curious if they, aside from the ethical reasons and resource utilization reasons they might have, do they believe in the science?
No, I don't think they believe in the science. Yeah.
What is it about the science that they haven't rocked yet, or do they what would this? Is that what you mean by long-term studies need to be created?
Right. So they don't believe that you can actually predict the things that you're saying that you can predict. So that's the reason why. Yeah.
Well, yeah, amazing presentation. I think that it's really hard to distill down and articulate the position of doctors, and I think you did an incredible job at that. So thank you for that. And I guess my question is what makes you so different than the other doctors, right? Why are you what do you think constitutionally kind of got you excited about some of this? Not just polygenic versus programmable genome, but just what do you think it is about you that kind of made you practice differently than some of these other things that you think are kind of much more dismissive?
Because I always want to do better, right? And people are already seeing me to do IVF. We're already doing genetic screening of embryos, which is not as good as it should be. So if there's a technology where I can select embryos in a better way to prioritize them, to give them a better outcome, I want to do that for them. And I really sit and listen to patients and talk to them about their concerns. And I just have heard over all these years what everyone's afraid of and what everyone wants. They think they're getting it, but they actually aren't. Right? So they actually think that they're getting something that's similar to whole genome sequencing, but they aren't. They think that if they do genetic screening of their embryos, they're already going to select for a baby that won't have the problems that they're fearful of, but that's not what we're doing.
So why do you think other doctors, aren't as responsive to their patients like you are? I know this is going to sound terrible, but I always thought that when you went into medicine, you were empathetic by nature. Yeah.
And it took 40 years for me to I get so angry. Why are they being so mean to their patients? And then it clicked. I was like, empathy is just not required. And so I think that doctors sometimes don't put themselves in their patient's position and shoes and think what would I want right now if I were a patient with the technology that we have available? What would I want offered to me?
Yeah.
They're not doing that. And I feel like we kind of have to switch their roles and say, okay, doctor, you're now the patient. what would you want? Wouldn't you want the menu of everything that's available to you offered to you, and then you get to choose? So I think that has a lot to do with it. I'm not saying that all doctors lack empathy, but I feel like with the technology that's becoming available as a resource to patients, it's making doctors engage less with their patients. So maybe like 7 years ago, you remember those like, don't replace your Google search with my medical education. Remember that? Like doctors would say that. I've been in social circles when doctors say that, like my patient came in with their Google search. Now doctors are insulted if you aren't going to Google. So they're actually saying things like, the reply is now Google it or Chat GPT it, right? So it's like things have kind of shifted in how we talk to patients about things. Yeah.
If I try to summarize what you're saying in terms of moving public acceptance, you're saying that fertility clinics are actually driven by what their patients want, and the patients are kind of driven by like what they see as celebrity stories. So are you saying that like kind of what we need is like an Angelina Jolie moment? Like she went huge about BRCA, and now
she did it too late though, right? Like I feel like, and yeah, I mean the thing is like look at the Obamas. Like for me, like she waited until she finished. They were out of the White House to talk about her IVF. Right. Like wouldn't it have been amazing if at the beginning she told that story, but she was saving it to sell a book? I mean, I'm just being cynical, but like she could have done so much for women, women with fibroids. I imagine Obama had really shitty sperm because he was a smoker. That's just me, projecting. He could have talked about male infertility. I mean, I think that would have been amazing too. He could be a spokesman for male infertility. But yeah, I mean, I think it takes that to, right, Angelina Jolie talked about BRCA and now everyone knows what it is, right? But I predict, I don't know for certain, that she did IVF with Brad Pitt to select her embryos for BRCA. Like that could have been a huge a opportunity for women to learn about IVF in that way.
Well, Dr. Aimee, I'm one of the genomic prediction founders, so I wish all IVF doctors were a little bit more like you and open-minded about these new technologies. I actually wanted to ask you about PGT-A, which probably during your career went through a similar evolution, where at first it was considered...
Back in the day, it was day 3 biopsy.
Yeah.
So 2005, and then closer to 2008 to 10, we went to day 5, absolutely. Yeah, I've been through all of that.
So a very analogous situation with PGT-A, it's similar to what the current situation is with PGT-P, is that the current method, NGS, is actually very noisy. Mm-hmm. And so the companies that are doing much more careful measurements of the genome of the embryos are able to also do PGT-A much more accurately. Mm-hmm. But it seems to me that most IVF physicians don't seem to realize this. And
right.
So there have been very detailed studies showing that many false positives and many false negatives are generated by the current NGS methodology. Mm-hmm. But it doesn't seem like, most of our revenue actually comes from PGT-A, mm-hmm. and a number of clinics have switched to our PGT-A, but still the majority of them have not. So I'm curious if you can just comment on that.
This is a very good point that most people don't know about. So
I'm
very excited for your answer.
Yes.
Yeah, I mean, PGT-A, well, I mean, just that's a great point. And I don't think a lot of fertility doctors know that, and they don't care to. Because when patients get the results back, this is the conversation. All your embryos are abnormal. We're going to go ahead and discard them. Click. And then the patient comes to me, and I look at her report, and I said, well, you have a low mosaic, a segmental, a chaotic, a high mosaic. I said, you just discarded embryos that had a high chance of turning into a healthy baby. And then they get angry. So, that's why I do what I do. I talk a lot about this stuff. I scream it at the top of my lungs. And in fact, many of you probably have seen the class action lawsuit against the PGT-A companies. Guess who's responsible for that?
Oh, really? Okay.
Shoot, was I supposed to say that? But yeah, because too many embryos were being destroyed that could be totally healthy babies. So I found a firm that believed in what I was saying. I'm not on the front page of anything, so I'm behind the scenes when it comes to that. But that was the only way we could get their attention. The only way. So guess what happens now? Clinics are now transferring mosaics, they're transferring high mosaics, they're rebiopsying chaotics, and these embryos are being given a chance for the first time, and that's what it took.
Yeah, in our data, we could see that Cooper and some of the biggest PGTA providers were classifying lots of good embryos as mosaic just because their measurement was so noisy they couldn't be sure, and they would just say it's mosaic.
Right, and the patient had no idea. They have no idea that that's what's happening. Yeah.
I have a question.
Yeah.
Actually, I have a two-part question.
Yeah.
So you, we talked about physician hesitancy. I was wondering about patient hesitancy, by which I don't mean like, can you convince patients to do it, but I mean, are there patients who are like pretty interested, but then have a big hesitance, like a big additional concern that you?
Yeah, so if you were to, 100% of patients, in my humble opinion, would do PGTP if the price point was the same as PGTA. So if you said, I'm going to offer you this and it's going to be included, they would all say, sign me up. Like, why wouldn't I? You know, the data's there. I can then just look at it and then decide what I want to do.
So basically,
So
no, there isn't.
there isn't a hesitancy from patients.
And then my second part is there, what happens when a patient who wants PGTP interacts with a doctor who is not really on board?
They come to me. Yeah, so then they have to find a clinic. So usually the genetic testing company will give them referrals to who's closest to them to see, and they have to move clinics. They have no choice. Or they then can't do it. Yeah. Yeah.
More questions?
I guess I just wanted to comment, this is really depressing, because like, what I'm really reminded of is like the stories that my mom and like my aunts had told me about trying to get women's health care around anything in like the 50s. Like, you walk into the clinic or to a doctor, and you ask for birth control or an abortion, and like this doctor feels like they have this invasive right to ask about like, well, why do you want this? Like, don't you know I have better things to do? There's other people who are softer than you. Like, this isn't so bad. Why don't you just deal with your problem? Like a lot of, in my opinion, like inappropriate and invasive assumptions being made. And it's like, I see a lot of that here dealing with my fertility clinic, where it's like every time I call them, it's like, why are you even asking? Why do you even want this? And it's like, well, for one thing, I would think it was very creepy and weird for my doctor to ask, like, why do I want this? Because that's not their job. Their job is to do the thing.
Right.
So I guess I see like a lot of depressing and sort of what I view as like inappropriate boundary crossing
Mm-hmm.
and like denying people information.
Yeah.
That's very sad.
Yep.
It explains a lot about my experience.
Yeah, people are inserting their biases into, like, they're making their own priorities their patients rather than the other way around, making their priorities whatever their patients are, you know what I mean? And so that's not how it should be. Yeah. Yeah.
So I wasn't really familiar in the past with the whole thing about the mosaic embryos. Can you just explain briefly? I mean, I know what mosaicism is, but can you explain why other doctors would think that just throw out the whole idea of a mosaic embryo, that it's worthless, to try to implant, and like how you're able to push back against that?
So part of it is the conversation that you have to have with the patient, because when you say embryo is mosaic, it's not labeled as normal. So on the report, normal is in bold, mosaic is not in bold, and it's not in bold just like the abnormals. So first of all, you have to have a conversation with the patient about what mosaic means, and people don't have time for that. So most doctors, if you set up a consult after your IVF cycle with your doctor, they'll book you out like 2 or 3 months. For me, it's, I got your report. Would you like me to send it over email right now, or send it over during our call that we'll schedule in the next 2 days, right? So that's not happening. So it's the lack of time that doctors have. So it's a lot easier to not explain it. And if you think about the money and the private equity and how these clinics are driven, it's all about the cycles. So it's a lot better for them to be like, oh, you have no normals, or there's just one normal, and not explain the mosaic part. We have to do another cycle for you. So it drives more cycles to the clinic as well. And I think it just has to do with the time people are, that have to take to have these conversations with patients and say things like, your mosaic is just as good as a euploid, they behave in the same way, same implantation and pregnancy rate. I know it's scary to have this word mosaic next to it, but I think it could be a perfectly healthy embryo, so let's give it a chance. So if you just use words like that with a patient, then the conversation is not that long of a conversation, but people just don't have them. Yeah.
I wanted to ask about like differences in per cycle IVF success rates between clinics, and I think Chase in the audience here has also done a lot of research on that. It seems like there's like quite a considerable variation in terms of like the highest performing versus average versus lowest performing clinics. Do you know like what are the main factors driving that?
I mean, I think a lot has to do with probably like the incubators they use, the media they use, the experience of the lab staff has a lot to do with it. So I think that has a lot to, I mean, I know just because like when you're in the restaurant business, you know what's going on in everyone's restaurant. Like I kind of know what's going on in all the different labs and who's good and who's not. Not that I would ever say that here, but you know, if a patient is like telling me they're considering these two options, and I'll guide them and tell them where to go. We're lucky in the Bay Area, most are really good. There might be two, which I won't say up here, that I would tell a patient to drive past and not go to. But for the most part in the Bay Area, we're very lucky. The clinics in the Bay Area are some of the best. I think the lab staff and the embryologist has a lot to do with it. I just created a blastocyst out of a 49-year-old egg in my lab. So she had one follicle, one egg, a beautiful day 5 blast, and I'm waiting for genetic results. Thank you very much. So I hope it's euploid. And on top of that, she has to do PGTM too. I don't know, but I know. But so yeah.
More.
Hi, I hope this isn't too unrelated. Do you think that they're discarding too many eggs at the freezing stage as well? I wondered about that.
100%.
4 cycles of IVF.
Mm-hmm.
Until they're only freezing the good ones.
Yep, I have a mantra, it's no egg left behind and no embryo left behind. So we do in vitro maturation of all immature eggs, and we do day 1 freezing. So if you have a germinal vesicle or an M1, the next day we'll freeze it. We also do the same for IVF patients. So if you have GVs and M1s, there are way too many immature eggs being discarded in this country. And the reason is lab staff. So when I've gone to the different labs, because I have credentials at almost 5 different IVF labs in the Bay Area, and I say like, why aren't you doing this? And they say, we just don't have the staff. We don't have the time. We don't have the time to keep the sperm in culture overnight and to culture the eggs overnight. It's a lot easier just to discard the immature and GVs and tell them that, you know, this is what you get rather than give them a chance. So I give them a chance.
That kills me.
Yeah, it kills, oh, I'm sorry. No, I didn't mean to. Yeah, but it kills me too. I mean, every egg, I'm like, no, I can't believe you threw all the, you know, if you think about how many immature eggs we're discarding in this country. So hopefully we'll get better at IVM in the future. Yeah.
Do you know any nutrition deficiencies or lifestyle factors or environmental toxins that affect the egg quality or the sperm quality? So if someone's preparing to do a round of freezing, is there any lifestyle factors that will actually improve?
Oh yeah, I mean, I could spend a whole day talking about that, absolutely. So I talk to patients about like their sleep quality, their exercise, how much they're drinking, if they're doing marijuana, supplementation. I believe in NAD boosters. I'm a strong proponent of those. CoQ10. And then depending on a patient's situation, I also include rapamycin, a 60-day course of rapamycin for some patients, and then ovarian PRP as well, even for my egg freezing patients. But yeah, I mean, it's...
Do you know rough effect sizes for any of these or each of these? So like, how do you measure the quality increase? Are you talking about a 5% increase?
For some patients, it's a tremendous increase. And the only way we can track it is through AMH levels, unfortunately. I can't give a woman a cup and be like, give me your eggs, let me see how many there are. And we don't know quality until we actually turn them into embryos. AMH is the only, you know, way I can provide some sort of quantitative, like a data point to show them that maybe things are improving, aside from follicle count.
Great. Let me quickly say, I interviewed like 10 clinics 5 years ago and asked if there's anything patients can do, and everyone was saying no.
Yeah, I don't believe in that.
I think why
Yeah.
a lot of doctors don't know.
Yeah. Yeah.
You mentioned a few times embryo whole genome sequencing, and I'm curious how you think of the advantages of that over sequencing the parents and imputing the embryos.
I see what you're saying, but I think if you have the way I see it is if you have the embryo, then you know what's possible for that couple, rather than seeing what's possible with that couple. But I think you can do both, and they could do that sequencing first and then also do IVF. I don't know if I'm understanding correctly, but I think that both things are powerful. Yeah.
More questions? No, that was great. Thank you so
Okay,
much.
great. Thank you.